All right, so it's about 5 past, so I'll just get started. So good morning, everyone. Welcome to the Yarning About Sexual Health through the 715 webinar. My name is Kezia Blackledge. I'm an Eastern Arana woman and a Public Health and Intelligence Officer at the AH&MRC. So just to let you all know that this session will be recorded as well and will be sent to you afterwards. I just asked throughout the presentations that everyone just place themselves on mute, and at the end of the webinar we'll allow about 10 to 15 minutes of questions for you to ask the presenters. And if you have any questions after the webinar as well, please also feel free to email me. So you'd have my email through the invite as well as after when I send the recording to each of you. And I'll also be sending through a feedback form as well for you to all fill out at your earliest convenience. And I would also like to ask if you could each put your full name in the chat as well, just for me to be able to take attendance of who came. So before we begin, I would just like to acknowledge country. So I'd like to acknowledge the lands of which I'm dialing in from today, which is Bidjigal and Gadigal land. I'd also like to acknowledge the elders past, present and emerging, and extend respects to any Aboriginal people in the webinar today, and acknowledge our non-Indigenous brothers and sisters in the health space. And may our ancestors continue to guide us on this journey we call life, and may we continue to remember that this always was and always will be Aboriginal land, and that sovereignty was never ceded. So I would like to welcome our first presenter, Naomi Hoffman, who is a clinical nurse consultant at Ilora Shoalhaven Sexual Health Clinic and a Camilla woman. So Naomi, you are up. Oh, I can't hear you, Naomi.
Can you hear me now?
Yeah, I can hear you.
Sorry, this headset's got like 2 mute buttons. Hi guys, I'm coming from the traditional lands of the Wadi Wadi people of the Darrell Nation. So that's where I'm coming from today. So I'll share my screen with you guys, and hopefully I can share some of my knowledge and experiences. We can have a bit of a yarn about talking about sexual health in the 715. So let me just bring up my screen. All right, can you see that? Yep, okay, great. So I normally work at the Ilora Shoalhaven Sexual Health Clinic, mostly based out of Port Kembla, but I do sometimes travel around. So yeah, that's a little bit about me. So I thought we'd just start with sort of the obvious. Why can yarning about sexual health be difficult? And a lot of this is pretty obvious to everyone, but I think it's important we acknowledge the things that can make it difficult for us so that we know and think about how we can work past them. So obviously there's shame. People can have a lot of shame talking about sexual health or talking about their own sexual activity. There's the stigma associated with certain types of sexual activity or just talking about it in general. You've got your men's business, your women's business, you know, at times a lot of people may wish to choose to talk about this stuff with somebody who's the same gender as them. You've got your misunderstandings. People can have a lot of misunderstandings about things about sexual and reproductive health. That can make it really tricky to sort of get to the bottom of all those misunderstandings. You've got us as clinicians or as health workers or health practitioners or nurses. We sometimes may not feel confident to answer any questions that somebody might have. So we then might go, I don't even want to get into that topic. And also we have our own lived experiences. I know myself growing up, the sexual health education I got from my family, my mum would go, you better not be doing any of that. And that's it ended there. So, you know, our own experiences can make it harder to chat about and have a yarn with our clients about sexual health. But the main thing is we do need to have a yarn. So why do we need to have a yarn? So we've got here, these are some statistics, and sometimes I don't really like to talk about statistics because I feel like it's just talking negative. But I think it's also being aware of the statistics that are out there at the moment. So like any other conditions, there is the gap between Indigenous and non-Indigenous rates and health outcomes. So STI rates are higher, and you can see there Especially in remote areas, it is much, much higher. But in more of the urban areas, it's still higher. So you can see gonorrhea, chlamydia, syphilis, HIV is higher amongst our mob. And it's something that we want to be able to do something about. And I think it's also important to think about, it's not just about an individual, it's about our whole community. So, you know, if a pregnant woman has an STI, it can affect the bub, you know, it can be passed to the partner. People can carry STIs for years without knowing it. And that might be, you know, passing it to a few other partners as well. And if it's left untreated, we've got some STIs can result in infertility. So, you know, it's not just about the individual, it's about our whole community. And I think it's good to have that sort of picture in our heads when we think about why we need to have sometimes what can be a difficult conversation. We've also got, you know, let's see when that's it. So at the same time, we want to stay a healthy community, and healthy people is a healthy mob. So, you know, keeping our health in check is really important. We're a strong culture. We've overcome so much adversity. We all know this, and I'm sure we can, you know, we want to make a difference in this area as well. And you guys, especially as health workers, you have such a great opportunity to offer this screening when you see people, because if they're coming in for a 715 health check, or they're coming in for their health visits, you have them there, like, you know, they're there, they're open to chatting about their health. So it's such a great opportunity that you guys can utilize. And, you know, we want to work together to make a difference in our community's health. And I know that's why all you guys went into health. That's why I did, you know, I want to help people and help the community. So you guys are probably familiar with the 715 forms, but I thought I'll include it, a little picture of it. So this is what is actually written about 715 forms. I think this is important that we remember. It says 715 health checks are not intended to promote a tick box approach, but instead to prompt us to think about our patient, their priorities, and opportunities for preventative health care. And I know often myself, you know, when I've had my 715s done, I felt like I'm being treated like a tick box sometimes. Someone will just go, you know, yep, 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 yep. But we have to stop and remember that these forms aren't designed to just do that tick, tick, tick. It's to help us and the patient sitting there, having a chat with them, having a yarn and going, all right, let's have a chat about this. Let's have a chat about that. So we want to utilize this opportunity. So let's have a look here. So this on the left here, this one here is the one for the 715 for adolescents and young people. So you got up to your 24-year-olds. And on the right, we've got our 25 to 49-year-olds. So you can have a look that our sexual health is included in the 715. And a lot of people will just read this beginning bit. Do you got any worries? Nah. And then just stop right there. But we want to actually remember this section is to prompt us to think about them and the opportunities that we have at that moment. So let's have a look. The same with the adults one as well. Is there anything you're worried about? So, you know, we want to think about this, and I'll talk about that in a minute. But first off, I thought I'd talk about how we're doing so far. So how are we doing talking about sexual health or offering sexual health screening in the 715? So first off, we're doing a pretty good job, I think. There was a 2020 Goanna survey. This is really just targeted at the young people. And it was across Australia, and 42% of the younger people were offered STI screening during a 715. 72% of the 20 to 29-year-olds were offered STI screening during a 715. So that's actually pretty good. It's a pretty good job, I think. The areas where things fell short was really with the bloodborne virus testing. So testing for syphilis, testing for HIV was not as good as the routine STI screening. And we will talk about that. And you can see that of those who did go ahead with the testing, 24% reported being diagnosed with an STI at some point, which is quite considerable. But like I said, this was just on young people. It doesn't include all ages, but it's something for us to think about we're actually not doing too bad a job, but we also want to build on that. We want to make these 42% offered much higher. So how we do that, that's the tricky part. So I work in sexual health and I talk about sexual health all day, every day, and that's my job. And it can be easier sometimes for me because when people come to sexual health, they know they're going to be talking about sexual health with me. Whereas with you guys, it may not be something that they expect to talk about today. So that's why it can be a little bit tricky, but I've put together some points and things that I think will really hopefully help you guys. But at the end of the day, I like to explain that you guys are the experts of your patients. You guys are the experts of your region, the experts of your clinic, and you will know better what's going to work for your patients. So I'm going to talk about that. So first off, I think it's really important to create a safe environment to have these private discussions with your patients. And like I said, it's an individual approach. You're going to know these patients better than other people, and you might know that the different ways that might make it easier to work with this person. If you're super awkward and you sort of sit there like, oh yeah, this part of the form, mate, or it's the old sexual health bit, that's going to make people not want to talk about it, or they'll just feel, oh gosh, this is awkward enough. So just trying to feel comfortable in yourself before you get started in the conversation helps to sort of normalize it. They go, oh yeah, they're talking about it, they must talk about it all the time. So that sort of helps settle things. Making sure you're in a private area and chatting to the client on their own. That is pretty common sense, but I do read some, I do have patients coming to me, not so much from Aboriginal run services, but from other services telling me, oh, they asked me all this stuff in front of all these people in a corridor. And so, that's obviously not going to be very good. Same gender health worker can be ideal, but it's not always possible. And they've done a lot of surveys out in community, and what community is also saying is that whilst they do particularly prefer a same gender clinician to talk about sexual health, that if the trust is there and they have a good relationship with the person, it's not always that important for some people. And I think that's something we can also keep in mind. And then also using and respecting what words they use to describe their genitals or sex. If whatever words they use, I just go with the flow. I tell some of my co-workers I work with, it's not an anatomy lesson. You don't want to be saying, excuse me, that's not what we call it. I'll just go with the flow. So that's some other sort of ways to create a good environment to get into the conversation. But how do we start the conversation? All right. So again, I know I reiterate this all the time. You need to individualize it, but I just want to make that clear that these suggestions I give is not for everyone. But seeing the client alone is ideal. If they're younger or if they've not come alone, you might need to ask, an aunt or mum to go. Or if people have come with their partner, I prefer just to talk alone. And sometimes I get totally two different stories about what kind of relationship they're in or whether there is a relationship, and talking to people together is not ideal. So some stuff I'll say is, thanks for bringing her in. Going to have a bit of a yarn about her health. You think I could just see her on her own? Or do you think I can ask you some personal stuff on your own, and then we can bring our aunt back in at the end, so that you're not totally kicking out the person. You're sort of saying, we'll just have a private chat, and then they can come in the end after you've discussed sexual health, So sometimes that can help as some ways that's showing respect, but you'll know, like I said, you'll know these people, and if ways that you might find easiest to talk to them about that. I also find that introducing to the client the idea about talking about sexual health today can help prepare them and normalize it. So rather than go, all right, now sexual health, you don't want to kind of spring it on them. Lots of people who've had 715s will know that this is going to be part of the conversation, but some people don't. And I prefer to go, we're going to have a yarn about important parts about your health, like medicines you take, family history, healthy eating, sexual reproductive health, throw it in the mix. And then people kind of go, oh yes, it's all part of my health, and they kind of have a bit of warning before you jump into the questions, if that makes sense. I also like to reassure their confidentiality. You know, people can be a bit nervous. So I kind of reassure, look, during 715, we chat about personal stuff. Everything's confidential unless there's issues with your safety. So, you know, these sorts of things just help, I think, set the scene to getting into the conversation down the line. So now it gets into the sexual health. So once you get up to the section of the 715 where you're going to talk about sexual health, some things I say is, did you know, tests that we recommend? Well, this is what I also think is important to understand, is that tests recommended for people can differ based on symptoms, age, and gender. And not a lot of people know that. And I like to say to people that we're not a cookie cutter community, and neither is anyone else. One lot of tests doesn't fit everyone. Okay, we can't just go test for you, test for you, test for you, you know, stamp, stamp, stamp. Everyone's individual, and we have to treat people that way. And so we want to ask them some questions to figure out what tests they need. And I will talk about what to do if someone doesn't want to answer questions, and you can only do what you can do. And if they don't want to have a yarn about it, that's okay, you know, but we want to try. So here's some things I typically ask. Can I ask you some questions about your partners and reproductive health? Or everyone's individuals and can have different partners or activity and need different tests. Can we have a yarn about any partners and reproductive health? Then we'll know what tests are best for you. So then people understand you're not asking this to be a sticky beak. You're asking this for a genuine reason. You're asking this so that you can find out information so you know what tests to do for them. I think that's really important, because otherwise they think, why are you asking me so many questions? Another thing is, you know, a lot of people, and I think this is an important message to share, a lot of people can have bugs, infections, sex infections, STIs, whatever word you think will be best, without knowing it. And the only way to know is to have a test at least once a year. How about we add that onto our test today? You know, just keeping it really smooth, you know, instead of going, do you give consent, you know, to do this? I think it's just easy to go, you know, are you happy to do these testing today? You know, regular testing keeps us healthy and strong as a community. Like we've talked about before, everything's confidential. So, you know, that's how I start to get into the trickier bits. These are sort of some of my flow words. Now, what to ask? Now, when I talk about what to ask, this is kind of like ideally the information you want to gather from your client you're having a yarn with. However, it's not always possible depending on the situation and their level of comfort. But these are the questions I like to know, and I ask if I can get all of them answered. So they are, do you have any worries about your sexual reproductive health? So that's the first question in the 715. Do you have any worries? But you don't want to stop there. I know that the box tick, but you want to keep going. Do you got any genital problems, or do you say you got any problems down below, or anything unusual happening at the moment? You want to know, you know, how likely is it that there's a problem going on? Do you have a regular partner at the moment? Now that's a really important question. Regular partner. So a lot of people might say, you have a girlfriend, you have a boyfriend, but that's not very inclusive. And we do know that we do have our LGBT mob out there, and we don't want to exclude them. So asking, do you have a regular partner at the moment, is a way to ask whether they have a partner without making any assumptions. Then, are your sexual partners fellas, ladies, or both? By asking that question, you're asking it in a respectful way, but also it shows the client that you'll accept any answer. They don't have to go, oh no, now I'm going to have to tell them something they're not going to expect. They go, oh, this person is open to any, like I can tell them the truth, because they won't be surprised if I say it is same sex or both sexes, you know. So that's something to think about. How many people do you think you've had sexual contact with since your last test? That one can be a hard question. I ask it if I find the situation's comfortable enough. I do try. And then I ask, what's your condom use like? Never, sometimes, usually, you know, just how often are you using it? It's also important not to forget other risk risk factors for infections in the other sections of the form. So in the other sections of form, there is a section on injecting drug use. So don't forget about that, because that can also put somebody at risk for certain bloodborne virus like your hepatitis C, or HIV, it is possible. So, you know, you just want to think about, keep that in your back of your mind as well. For women, I will typically ask, when was your last period? Are they regular? Are you trying to get pregnant? Are you taking anything to stop pregnancy, or like, are you on any contraception? So just kind of add that just to think in my head, is there any chance this lady's pregnant, or does she need some help with contraception if that's what she wants? So what if they don't want to answer my questions, or if you have any yarn with them and they're just like closed off like a wall? Sort of just say, look, everyone's individual. These questions help us figure out which test would be best, you know. But if they don't want to talk, I'll say, look, if you don't want to talk about this sexual health stuff today, how about, if you're happy to, we can run the tests, and if there's any problems, we can chat more about it then. You know, you want to still get their consent to testing, but some people, if they don't want to talk about it, they'll still agree, oh yeah, do the tests. We'll talk about it if there's a problem. And sometimes, you know, we'll find an infection or something like that. Or I'll say, I can see you're overdue for a routine sexual health check. You happy if we add them on to the bloods and the testing today? And by using the word overdue, or just saying you're due for your routine, it helps remind people this is part of your regular health check. It's not something, you know, that's off to the side. It's part of your routine checking. So I like to use that kind of language. Now, let's have a look. Who gets what tests? Let's look at the 715 guide. But I must say, I put some crosses because the 715 guide needs a little bit of updating, but that's okay. So let's have a look on the left. We've got our youth template. So we've got chlamydia, gonorrhea in the urine for male and females, or they can do a self-collected vaginal swab, or a swab if there's an examination, but let's keep it simple. We've got a urine, or the woman can do a swab, but have a look. Have you noticed this line here at the bottom of the first, oh, here, I'll use my mouse. Here, throat and anal swab for men who have sex with men. How are we going to know who's a man who has sex with men if we don't ask these questions like we talked about in the last slide? How do we know we're doing all the proper testing they need if we don't ask? So this is why we need to ask. If you can hopefully see with my mouse, this is here. Here it says syphilis. For areas where it's very common, men who have sex with men or others at high risk. However, this recommendation has changed, and it is recommended to offer syphilis screening routinely to all Aboriginal and Torres Strait Islander persons, not just the where it's common. And it is on the rise. It keeps me very busy. And then we've also got our trike there as well for people under 30. You've got your male, female, remote areas, but that can easily be added on. Now let's scroll down. Bloodborne virus screening. You've got your hepatitis B, if you don't know whether they've been vaxxed or not. Hepatitis C if risk factors, and most of those risk factors are around any sharing of needles, whether that's through injecting of drugs, through tattoos or piercings in the backyard, steroid use. Some people aren't as blessed as some of us with some lovely tan skin, and they use some tanning injections to get a nice glow. Anything where needles going into the body, if it's not done in a sterile, professional manner. And I've crossed out these HIV if risk factors. Majority of my Aboriginal patients that I look after with HIV did not have the typical risk factors or that people would immediately assume. And I think the recommendation is also changing that should be part of a routine screen as well. So that's why I have crossed those off. And you're already going to be doing bloods for these patients anyway. You can see here. So it's as simple as adding it on once you've had the yarn with them. So it's mostly just adding on a urine, and some people do a urine anyway. And we've got here for the adults. It's the same kind of thing with the adults. I've just kind of crossed this and this because like I said, the recommendation has changed. So yeah, I hope that makes sense if you have a look at these. So these are the templates. So I just want to have a look. There is also this one here, the Australian Consensus in STI Testing Guideline, and see if this will open for me. Oh, doesn't want to open. That's all right, I have it up. Can you see it on the screen? Hopefully, no? Oh, that's all right. What I'll do is I can share it around rather than faff around with it. I'll share it around, but basically it just says that young people should probably get tested 6 monthly. And then everyone else should probably at least be getting tested 12 monthly. There's a few different things. If they're men who have sex with men, they should get tested every 3 monthly. Don't wait for the 715. You know, if someone's got symptoms or they haven't had a test in a while, you don't have to delay. I can share that at the end. But that's all that shows, really. That we don't need to just wait for the 715. We can offer routine testing if they present for other things. So I won't take too much longer, but I'll just show you a couple of examples. So let's practice using the 715 tool. So you're seeing Kayla, let's say Kayla for 715. She's 26 years old. She's got no symptoms. Her last sexual health test was a year ago. She's never had a positive result for an STI before. Has a new boyfriend. Sex with fellas only. And since her last test, she's had sex with 3 people, and she sometimes uses condoms. So let's have a look at this form. So can we see here? So she'll automatically be getting those. So she should be getting chlamydia and gonorrhea on a urine test. She's under 30, so she should be getting the trichomonas test. And like I said, she should be offered syphilis and HIV, and she can actually have Hep B testing if that's not on file. Does that make sense? I hope that makes sense. So I've just kind of summarized it here. So if it's been over a year, so it's not like she's had a blood test last week or she's had this done recently. So we can certainly do those testing for her. Hopefully that makes sense. So we've got, this time I thought I'd do a fella one. So we've got Jimmy, and I've made him a little bit more complicated. So Jimmy's coming for his 715. He's 18. He's got no worries. Never had a sexual health check. He tells you he has sex with men. In the last 12 months, he'd sex with 10 fellas. Sometimes he uses condoms, and he did say he injected some methamphetamine about a year ago. So let's have a look at this form again. What kind of test is he going to need? So here we go. So chlamydia and gonorrhea from the urine and the throat and rectal swabs. So hopefully you guys thought that. Throat and rectal swabs. Can do trach from the urine, and he should definitely be having syphilis, HIV, Hep B, and Hep C from the blood test with his routine stuff he needs. Now, there's more information about this online, and this isn't a PrEP webinar, so I'm not going to go into it deeply. But I just want to raise the awareness that there is a medication called PrEP that can stop someone from getting HIV, and it can be prescribed from a doctor. It's really mostly encouraged to be used with people who are in increased risk of HIV, and that's men who have sex with men. Anyone having sex with someone who's HIV positive, only if the HIV positive person's not on medicine. As people living with HIV with their medication, if they're taking it, it actually stops them from being infectious. They can't pass it on to anyone and live long, normal, healthy lives. So you can also consider PrEP for people who are sharing needles. Can be considered for that. So that medicine is out there, and there's more that you can look on it, but I don't want to get too much into that, but it's a fantastic medication you can always keep in the back of your mind. So some great resources. I'll just quickly show you these. I know Nathan is going to be having a bit of a yarn with you guys now, so I don't want to take too much of his time, but some great resources. I love these resources. You've got the Take Blacktion website. It's got STI and HIV information for our community. It's got funny videos with the fellas from Black Comedy, and you can ask anonymous questions to a nurse. I send my patients that way all the time for information. If they don't want to have a yarn with me, I text them the link to the website. Check this website out when you have some free time. Another one, Better to Know. It's again designed specifically for our mob. The patient can organise an SMS reminder for regular testing. So if they're at slightly increased risk, they can pop their phone number in and it'll remind them, you're due, it's 3 months. You can also use it to anonymously SMS some past partners if the patient has a positive result. So if you've got a girl with an infection, you can use that website to let her old partners know without like outing her or creating any kind of shame in the community. We've got some more resources, Young, Deadly, Free, videos for young people, videos for elders, aunts, health professionals. More info there, guys, on how to talk about sexual health. And it's got a great video on that medication PrEP for Aboriginal and Torres Strait Islanders. this consensus STI testing guideline that I was just referencing, which really shows you how often people should be tested. We've also got these two ones, Us, Mob and HIV, the 2021 edition. It's got just the new edition recently came out not long ago, and it's got lived experience yarns from people in the community experiences and great information about HIV. Also, you've got the Ending HIV for PrEP information. And lastly, we've got Let's Yarn for health professionals, and there's more videos there on talking about sexual health with Aboriginal and Torres Strait Islander clients, videos on HIV, videos on STIs. So that's my last slide, but I think the most important thing is just giving it a go. And some of those techniques I hope you guys will find really useful about how to sort of smooth the conversation a bit. And also, you know, just the stuff that keeping in our minds, not all bugs have symptoms. We don't know if someone has an infection unless it's on the paper in black and white. And so a lot of people go to me, I don't got no symptoms, I'm fine. Well, we don't know, you know, lots of bugs have no symptoms. So that's sort of the important thing to sort of hopefully encourage your clients to get some testing. Well, I'll hand back over to Kezia, because I think Nathan's got some stuff to have a yarn about.
Thank you very much for that, Naomi. So now Dr. Nathan Ryder, who is Acting Head of the STI Programs Unit at Ministry of Health, will be presenting as well. So take it away, Nathan.
Thanks, Kezia. Yeah, so my name's Nathan Ryder, so I'm a sexual health specialist that clinically works in Newcastle in Hunter, New England, but also at the moment acting head of STIPU, working with Heather, it's on the line as well, and it's going to talk after me. Thanks, Naomi. It's hard to go after such a great talk. It's one of the problems of going second if the first person's so good. I'm on Awabakal land here in Newcastle, and great to have so many people on the line. I'm just going to share my screen, so bear with me 1 second. Share. Okay, can you see that? Yep, excellent. Okay, so basically I'm going to be focusing on the part of it after you've got the test results back. So Naomi's done a really good job of explaining those really important first steps with having the conversations and doing the tests. But of course, you know, for the 715 to have an impact, we also need to then, you know, manage those results. And that's, I think, sometimes one of the downsides of 715 is what Naomi was talking about with the you know, the ticker box nature sometimes. So we've got to remember that we've got to use this information that we obtain to really, you know, work with that person to work out how we can help them improve their health. So let's go through like a practical example, I suppose. So so Naomi's first case was Kayla, who I imagine Naomi made up. So I've made up some results for Kayla, and we're going to go through. So I'm aware that probably most of the people on the line won't be actually giving out antibiotics. But I am going to touch on that a little bit, just so that everybody knows how we do treat things. But really focus on the fact that managing an STI is about more than just antibiotics. So let's have a look. This is what might come back for the STI part of a 715 check. So there's a lot of stuff there, but so we'll just break it down and go through one by one. But just to start with, just an overview. So this side, this is all the blood tests. So Naomi's had a syphilis testing here. She has a HIV test. We didn't do the Hep B test because you know, in the original 715, we checked her vaccine status. We could see she was fully vaccinated as a child, and so we're not worried about hepatitis B. And then we did a low vaginal swab, and we checked for chlamydia and gonorrhea. So what we can see here is we've got a positive though. So we've got a detected result against the chlamydia PCR. So that tells us that Kayla's turned up with a positive chlamydia result. So how do we manage chlamydia? And that's probably going to be the most common one you'll be dealing with. So I've put up a shot there of the STI treatment guidelines. So that's where the doctors in your clinic, that's where they'll predominantly be going to get advice around what antibiotics to use. And so the current recommendation for treating chlamydia is to use either doxycycline or azithromycin, and you're probably most used to that single dose of azithromycin. But one thing that is changing is we're starting to prefer doxycycline, which is 1 tablet twice a day for a week. So people are probably going to need a little bit of support around how to take that, because taking it for a week is a little bit different than taking it for the day. But we still do have the option for that single dose if you think people are not going to be able to manage to take a week's course of medication. So that'll treat it, okay? But if we left it there, we're probably doing our patients a little bit of a disservice, because there's probably a little bit more that we can do with them around this. So if you scroll down in that same guideline, there's a few other things that we need to do. So the first thing is that we need to let them know that they shouldn't have sex for 7 days after this treatment. So we don't want them passing it on to their partner during the course of that treatment, and then when they finish, they catch it back from the partner. So we strongly advise them to either not have sex, or if they can't manage that, to consistently use a condom for 7 days during the treatment. The next thing is to talk to them about letting their partners know, so partner notification or contact tracing. And for chlamydia, we would do that for the last 6 months, and we'll unpack that a bit more in a minute. And then the last thing we would do is talk to them about putting in a recall to retest in 3 months' time. So unfortunately, a lot of people, about a third of people we treat for chlamydia, will still be positive at 3 months, and that's not because the drugs don't work. We know they work really well. It's just that if you've had chlamydia once, you're more likely to catch it back. And it's really important to use that recall system in your electronic record, because most people, if you say come back in 3 months, 3 months is gone before you know it, and it's very hard to remember. So you really want to actively recall them for that 3-month test. So partner notification. So this is, I guess, like one of the really important things that can be done that isn't related to antibiotics, and it's really good if it's done as a team-based thing, and it's not solely the job of the doctor writing the script. So this is a tool I've just got up. So that's off the STIPU website. It's got a few pages there. Some of it's around having the conversations and doing the test, but the page that I've snipped off is really around the contact tracing. It's a pretty good one-stop shop, I think, for how far back you need to go, and some tips, particularly Aboriginal specific tips around how you might have that conversation. So reading through that, it probably gives you almost all the information you need. In terms of like the practicalities of it, I think all those things Naomi said around being sensitive, making it routine, getting permission to have the conversation, all those things that you do in terms of the testing, they're exact same things you do in terms of the contact tracing. And most people will respond to that conversation if they're respected and given the right information before you launch into the questions. So the next thing is, Naomi's already put up there, but the Better to Know website. So if people know the partners, they've got SMS or emails, but they just feel a bit shy to let them know themselves, you can direct them to the website, or often we'll just help them and do it in the room. If we can get 3 numbers, chuck them all in, it's all done before they've left. And the last thing is the SHIEL website, or the New South Wales Sexual Health Info link. So they will actually help with contact tracing, and they'll do it for you if it requires social media. So I've just done the snip, and if you do that little down arrow that's in the middle there, you basically get down to putting in some information for them to do it. So she will definitely help, and they'll prioritize syphilis in particular. And so we actually had a really good example of this working well. So we had a syphilis case in our area, in a young person who had about 15 contacts, but they didn't really have great details. They just they knew them, but they didn't really have all their details, and some of the phones were disconnected, or they weren't their phone anymore, they'd been passed around, but they did have social media for all of them. And so they passed it on to SHIEL, and SHIEL managed to find every one of them on one of the social media platforms and sent them private messages. And then those people made contact with their local AMS, and virtually all of them ended up being tested, which would not have happened if it was trying to physically find them in the community, or send them a message, or phone them. It was just impossible to do in that particular group. So we were a bit nervous at first, because we'd never done this in an Aboriginal community, particularly a regional one. But it really showed that by working together, because it really needed the SHIEL staff working with the local clinic staff to get enough information to identify we had the right people. And in the end, it really paid off, and it showed that this can be done. So don't forget the Shoal website. So after we've done the contact tracing, so we've treated the person, we've put in our recall to retest them, and we, let their partners know. So what else might we do? So I guess the other thing is what Naomi mentioned is that this is an opportunity, right? So someone's come in, they've had their check, maybe they had a bit of a conversation there, or maybe they didn't want to at that time, they just did the test, but now they've turned up positive, right? So perhaps this is a moment where they're willing to engage in a conversation about reducing their sexual health risk, right? So they're willing to talk about things that they might practically do. So this tool's on the Stippy website as well, and it's not Aboriginal specific, but it does talk you through, like, how would you do a brief intervention? And you're probably used to doing brief interventions for smoking, say, and I think it's, you can apply the same logic to sexual health. So we're not trying to lecture people here. We're not trying to say, you need to stop having unprotected sex or you'll get these bad infections. It just doesn't work. I'm yet to meet the person who doesn't actually know that unprotected sex can lead to an STI. So your goal here is not to educate as such, right? It's to work with them to identify some practical thing that they could change in their life that might reduce their risk. And for everybody, that might be a little bit different, but this tool gives you some ideas of where you might take that conversation. I can't see the chat either, actually. So if anyone asks the question, Kezia, do you want to just pass it on? And feel free to ask questions in any of this. So let's step back to the results, but just mix it up a little bit. So let's say she didn't test positive for chlamydia. Let's say it was gonorrhea. So gonorrhea is a bit less common than chlamydia, but Aboriginal people are a little bit more overrepresented with gonorrhea in New South Wales, as Naomi put up there. So how would that be different? And it's actually not that different, really, but there are a couple of things just to flag. So the first thing is, unfortunately with gonorrhea, we need an injectable treatment. So we can't just give them a single dose. So it's a little bit more complicated in terms of sort of arranging that. And the new thing that came out a year or 2 years back was, if they've got throat infection, we need to give them an additional increased dose of azithromycin along with the injectable. And so for that, we need to be doing the throat swabs. So we need to know that they're men with male partners. And then it's much more likely to clear if we use this higher dose. And the other thing is that when they do come back for treatment, because gonorrhea tends to become resistant to many antibiotics, we want to make sure we're getting a culture. So what a culture means is we're actually growing the organism, whereas the PCR test that you do for your standard test doesn't grow it, it just says if it's there or not. But by growing it, they can do what's on the right hand side of that screen, and they can see each one of those discs is antibiotics, so they can see which antibiotics are going to work for that gonorrhea. So that can be useful for the individual patient, but it's also really useful to track what antibiotics are going to work for gonorrhea. So trying to remember to get that culture when they come back is important. So the third thing that we got here was syphilis, and syphilis is really complicated. So I'm going to touch on it, but I'm not intending you to feel comfortable to, interpret syphilis results and treat it by the end of this. But I just touch on it because it is such an important thing at the moment. That unfortunately syphilis is increasing in the population as a whole. We used to almost solely see it in remote communities and gay men, but now we see it in the general population. And the latest data, which actually hasn't been released as yet, but it's showing that in New South Wales, in pregnant Aboriginal women, they're significantly more likely to have syphilis than pregnant non-Aboriginal women. And so we're really a bit concerned there. We want to make sure the syphilis testing rate is high and it's getting managed properly, particularly in pregnant women. So how do we interpret this? So basically with syphilis, there's two things. So first we get our total antibody, and if that's reactive, it means they've either got syphilis or they've had it before, one of the two. And then we get our RPR, which is a number. And it's by the combination of those two things that we try and work out, have they just had it before, or they got it now and they need treatment? And that's a really important thing to bear in mind, because many people have had syphilis before. And the last thing people want when that's the case is that every time they have a 715, there's a bit of a panic, and they call back and they're worried about the confidentiality. So making sure that the medical staff in particular can distinguish that is really important. And this is a brand new tool that's probably useful for everyone. It's probably mostly directed at GPs, but it's like a 2-pager that, you know, in a nutshell, tells you when to test for syphilis, how to test for syphilis, and how to interpret the serology. So essentially, you know, we just need to follow this flow chart through, and then we work out if we need to treat them or not. And so what do we need to know? So we need to know a few things. It's not like chlamydia and gonorrhea that's like positive or negative. We need to interpret in the light of quite a lot of information. So the first thing we need to know is, do they have symptoms? And the second thing we need to know is, have they recently had sex with someone who was diagnosed with syphilis? Are they a contact of syphilis? And then we need to know, have they had syphilis before? Were they treated? And what were their most recent test results? So we need all of that, plus those 2 tests. We need to put all that together to work out, does this person currently have syphilis or not? Right, so you can imagine in Kayla, who came in, had her 715, and let's say she'd been negative at her last one. So we know it's a new infection. There's quite a lot of stuff that needs to happen, right? So we really need to get her back. We need to get her back. We need to get her, you know, in with the doctor, and we need to go through all this information. We need her to feel comfortable with all these questions being asked. So we can, if we look at those answers up there that we know from the fact that she came in asymptomatic for 715, we could follow that down. So she's positive to syphilis. Her RPR is positive, and then she's no documented previous treatment. So that means it's possible early or late syphilis, so we're going to treat her. So that's how easy it is to follow that flowchart down, to know if you have to treat her or not. But there's a few red flags, and, you know, this really, you know, should be part of the medical assessment, but, you know, sometimes it's hard to get people back. Sometimes there's a bit of a gap, right? And sometimes different people know different things about the patient. So I think it's important to know what the red flags will be. And there's quite a lot there, but it's actually fairly simple at the end of the day. So if you've got a female with syphilis who's pregnant, then we would consider that an emergency. So we need her treated ASAP, because the syphilis can be transmitted to the baby at any point in pregnancy, and the baby can be infected while it's still in the womb. So we need to get her back straight away, right? So we need to know if the lady's pregnant, and sometimes that might be, we need to get her back and do a pregnancy test, because maybe we don't know. If you know that she's a young lady who's having unprotected sex with a partner, like she may well be pregnant and just hasn't told anybody yet. Or she may not even know. So trying to get her back as soon as we can. Now, a child, and I think that goes without saying, I think most people will consider positive syphilis results in a child would raise some red flags, but just to be clear, it definitely does. They definitely obviously need both medical assessment and child protection assessment. The other thing is, it's very hard to get benzathine penicillin in many places. So if you can't get it, this is one of those situations where you want to just refer immediately. You want to get this person treated as soon as possible, so there's no sense, you know, feeling about trying to get it if you can't get it. Sexual health clinics are more than happy to help. Anyone with allergies to penicillin, penicillin's our preferred treatment, so if you've got an allergy, get some advice. And we need to be concerned, this is mainly for medical things again, but people that have got neurological symptoms, which is mainly changes in sight and hearing, they need to go to hospital because they'll need intravenous treatment. And often, even if you ask that question, you won't know, because people often say, oh, yeah, I have noticed I've got a bit hard of hearing lately, but I didn't think anything of it. I didn't think it was related, so I didn't tell you. So we actually make sure we ask. So any of those things you can refer to a sexual health clinic, but ultimately, sexual health clinics are more than happy to see any syphilis case, either just to provide advice on the phone or to actively see the patient. No questions asked, we would definitely see them all. So basically, just to summarize, so what's different about syphilis and the others? So basically, it's just a lot more complicated. So just get advice, and that you need to, if they're female and pregnant, urgent. So that's it really. So I guess my takeaways is thinking about, well, what am I trying to say? So Basically, I'm saying treating STIs is more than just an antibiotics, and the whole team should be involved in this, right? Because it is a sensitive conversation, and people that have done the 715 initially had those conversations. They may well be the best persons to have the conversations that are positive about letting partners know and about reducing their risk. There's heaps of resources available. So Naomi put up lots. There's a few in here, but if you go to those websites like Take Blackledge, Stipu and Shill, that'll then take you off to everywhere you need to go. Using your recall system. So a lot of this is about remembering to test regularly and then remembering to get them back for treatment and the follow-up tests. So using your electronic system and setting active recalls is really the key to making this work. And then the last thing is just always ask for help. So particularly I'm the director of a sexual health clinic in Hunt, New England, but I know all of the clinics across New South Wales are more than happy to provide advice by phone or in person at any stage you need it. And that's all. And back to you, Kezia.
Thank you so much, Nathan, for that presentation. I'll just pass on to Heather Mccormack, who is a Wiradjuri woman and the Senior Programs Manager at Stipu. So thanks, Heather.
Hi, I work at the STI Programs Unit with Nathan and with a few people. I'm really pleased to see Take Blackledge mentioned a few times in the presentations because that's a program that I lead, and it's really exciting to see that that's so well recognised and appreciated. But unfortunately, that's not what I'm going to talk about today. I'm going to, it's a bit of a dry ending to the evening, but I'm going to talk about a program that I've developed over the last couple of years with Dr. Chris Bourne and with Nathan about increasing STI testing in ACCHS sites. So let me just share my screen. Is that doing what I intended it to do? Oops, that's the wrong one. Sorry. Okay. Sorry, guys, hang on a moment. I just can't find my notes while I've got this shared. This was bound to happen. Sorry.
I think, Heather, you got to do presenter view.
Yeah, I've got it. Now is that working? Are you seeing the thing? Yeah, good. Okay. Yeah, so this is the presentation about the capacity building site visits. So this piece of work began in 2019 when the syphilis outbreak that had been affecting remote communities across Northern Australia had moved into South Australia and then into Victoria. So as part of the New South Wales Health syphilis response, Chris and I coordinated site visits to 5 ACCHS that included urban, regional and remote sites. And we worked with the sites to develop a co-design process to identify strategies from within each ACCHS that we could kind of operationalize to increase STI testing. And the intent here was to identify ways to increase STI testing and particularly syphilis testing within existing consultations and without requiring a lot of extra work or resources from the site. So the 3 broad aims of the program, which you can see there, were to increase STI testing in 15 to 35-year-olds generally, to increase STI testing within the 715 specifically, and to increase the proportion of STI tests that included a syphilis test. So this was planned as a consultation and capacity building exercise. We all recognise that ACCHS staff are the experts in your own local context and in the strengths of your service. So our aim was to provide support from Stipu and AH&MRC to help make the most of those strengths. And to achieve this, we leverage staff champions within each service to co-design an intervention package that we thought would work in that particular local context. So some of the site visits had stronger outcomes than others, which is not really surprising as the local contexts are, again, very different. This is one example of an intervention package that was co-designed with staff champions from a regional remote ACCHS in 2019. We facilitated a strengths-based and solution-focused co-design workshop with staff champions, and out of that we developed a 4-part intervention package that was implemented at the service prior to COVID-19. So the 4 components of the intervention package were electronic prompts and shortcuts in the patient management system, which I'll talk a little bit more about on the next slide. Credentialing of nurses and Aboriginal health practitioners to collect and order tests, and related to that, having a GP pre-sign pathology forms for tests collected by nurses and Aboriginal health practitioners. And finally, improving the data reporting at the services, both internally at meetings and through enrolling the service in the Atlas Sentinel surveillance network. So we then commenced a comprehensive mixed methods evaluation, which has included statistical analysis of patient medical data and qualitative interviews with staff who had been involved in implementing the intervention. So that included managers, GPs, and nurses. And the early findings from the evaluation are fairly encouraging. We definitely saw an increase in STI testing and syphilis testing in the period being evaluated. Although, unfortunately, it's also clear that COVID-19 had an impact on how well those intervention components were being implemented, which I'm sure is not a surprise to anyone. So I'll quickly go into a little bit more detail on the electronic prompts and shortcuts, as they were the component of this particular intervention package that seemed to have been most successful. On the left of the screen, you can see the prompt tree for a 715. So if the patient is in the target age range, the clinician delivering the 715 receives a prompt from the patient management system to question if the patient is sexually active. And if they have recent sexual activity, the patient management system auto-populates a pathology test request form that is inclusive of syphilis and HIV. And on the right, you can see the shortcut for a comprehensive STI test, which again auto-populates a pathology test request form that is inclusive of syphilis and HIV. So both of these tools are about making it as easy as possible for clinicians to request comprehensive STI screens. They don't need to remember to write it in. They don't need to know what the correct notation for the lab is. They just need to indicate that the person requires an STI test, and the rest is done for them. So as I said, this project started in 2019 as part of the New South Wales Health Syphilis response, and we completed 5 site visits in 2019 across urban, regional, and remote settings. And we spent some time developing and refining the co-design process so that it was more adaptable to different settings. Unfortunately, just like everything else, this project experienced pretty severe COVID-related disruptions in 2020. And the site visits were placed on hiatus due to travel restrictions. So this meant we were unable to provide appropriate follow-up to the sites that we'd already worked with, and we also couldn't plan new site visits. But we made the most of this forced hiatus to conduct a really robust evaluation of the intervention package that we'd implemented at one of the sites. And we're expecting that the learnings from that evaluation will inform this work moving forward into the next year or two. So in 2022, we expect to complete the evaluation and pick up the site visits again, with both new sites and return visits to sites that we've already visited to try and breathe some new life into the program. So what is next for this program of work? We're completing and disseminating the evaluation, and we're planning to both publish that and also develop a plain language report that contains the important information in an accessible format, because everyone's busy and doesn't necessarily have time to read really extensive and comprehensive write-ups of evaluation methodology. And we can also provide in-service presentations on the project as well. So next year, STIPU and AH&MRC will proactively contact sites that we think the program would be a good fit for. But we're also super keen to hear from any sites that might be interested in putting themselves forward for the program. So speak to Kezia or myself if you'd like to find out more. And that's it from me. Here is where to find me if you have questions or if you would like to know more about how this program might be a good fit for your service.
Perfect. Thank you so much, Heather, for that. And we've finished all the presentations, so I'll just allow the next 5 to 10 minutes if anyone has any questions, if you'd want to